Diagnostic studies for cancer, they do cytology testing, so that's going to be retrieval of cells. They can do that with biopsies. They can take a piece of a tumor out, any of those things, and send it to pathology, and they will determine what kind of cancer it is, what kind of cells it is, and those things. Endoscopic exams, that's going to be your EGD, the esophagogastroduodenectomy. So they're looking down into your esophagus, into your stomach. They can also do biopsies then. They can irrigate. They can do take a look at everything and see if anything looks to be abnormal. Radioisotope scans are going to be nuclear medicine, where the patient is injected with a small amount of a radioisotope, which is called a tracer, and they can determine if anybody has any hot spots. So on like a nuclear med scan, they would do that, and if a place has an increased amount of blood supply or just a hot spot for that tracer, they can determine that the cancer has spread, or that's where the primary tumor is. A PET scan also uses a radioactive drug where cells are more active than normal. So this is a picture of what I was talking about, the hot spots. This is a PET scan, and you see in picture A, all of the red and the yellow, that is metastasis of that tumor. And then after treatment is picture B, and you can see most of the reds and the yellows have gone away. So we can do, the physicians will do biopsies. Percutaneous is through the skin. Endoscopic is through a scope, so that can be, as I said, in the esophagus, in the stomach, or anywhere in the colon if they do a colonoscopy. Also surgical biopsies, a laparotomy, that is opening up the abdomen. Craniotomy, of course, is taking a tissue sample from somewhere in the brain, and a thoracotomy is inside the pleural cavity where the lung tissue is. Other things, CAT scans, MRI, chest x-rays. We talked about tumor markers the other day. These are blood tests, not reliable screening tools for most things. But another one that I didn't mention the other day is prostate-specific antigen, which is PSA, which is something that men should have tested every year to see if it's elevated and if they're an increased risk for prostate cancer. There are some genetic markers. The most common ones are BRCA1 and BRCA2, and these are genetic markers that they can determine that a woman or a man has an increased risk of getting a breast cancer. So cancer treatment, there are 3 goals. Of course, the best goal is cure. If not cure, then let's control the disease. If they can't do any of that, let's make the patient's last days a little better, or improve their quality of life with palliative care. So factors for determining which therapy is used: histology of the cell, the grading, staging, and the physical and psychological state of the patient, and primarily what are the client's wishes. You know, just because they have this disease doesn't mean that they have to be treated for it, and that is their decision to make. So use for cure or control, remove only as much tissue as necessary and spare the normal tissue. Also debulking, that's a procedure. If the tumor cannot be removed completely, they will debulk or take some of the tumor out to relieve symptoms, to improve perfusion to that area, just whatever it is that they need to do. And debulking first can also make chemo and radiation therapy more effective, as they have reduced the tumor mass before they start treatment. Typically, they will follow these things with chemotherapy or radiation. So supportive care, cure or control not possible, then we determine, okay, what do we need to do? Are we going to do palliative care? Do we need hospice care? You know, what does this patient want, and how do they want to spend their last days? Some of the supportive care is maybe putting in a PEG tube and starting gastric feedings. Sometimes this starts with an NG tube, which is temporary, and then if the family and the patient want it because they can't eat, then they can get a PEG tube, which is can be temporary or permanent depending. A CVAD, of course, they need a central venous access device. So sometimes that can be a bilumen, a triple lumen PICC, a midline catheter, or long-term things, a subcutaneous port, which they can give the medications through, they can draw blood from. It is an increased source of infection for these patients, but it is a necessary evil. And then a laminectomy, sometimes if there is spinal cord compression, they will go ahead and take out the lamina, which is that spiny process on the vertebrae, to give some more area so the spinal cord is not compressed. So we're going to talk about chemotherapy, and we're not going to talk about specific medications because everybody's recipe is different if they're receiving chemotherapy. So the goal of chemotherapy, of course, is to destroy these tumor cells or to slow the growth of the tumor. Unfortunately, chemo does not distinguish between normal cells and cancer cells, and it's an equal opportunity cell killer. But most of the side effects that we see for patients who have chemo come as a direct effect of these normal tissues being damaged. So here's an example of the effect on these areas. The bone marrow stem cell, the effect of that is there's bone marrow suppression. So the bone marrow is responsible for our white blood cells, our red blood cells, and platelets. So with bone marrow suppression, there are less white blood cells, increased risk for infection, less red blood cells, causing the patient to have anemia, less platelets or thrombocytopenia, which increases the risk of bleeding. Cells of the GI tract are really susceptible to chemo. There's a lot of sloughing off of the skin. There's a lot of mucositis, stomatitis. They get sores in their mouth. It's very difficult for them to eat, to want to swallow anything. And it also causes nausea and vomiting and diarrhea. The hair follicle cells are also susceptible, and that causes alopecia, which is a fallout of when the hair falls out. Neutrophils are also affected, and that causes leukopenia, which is a low white blood cell count, which puts the patient at risk for infection. Some of these things have acute toxicity, delayed effects, and chronic toxicities. So acute toxicity is right now. So we know if our patient's having an anaphylactic reaction, we can see that. They're covered with the rash, they're covered with hives, their throat and their mouth is swelling shut, they're having difficulty breathing, they're having wheezing. That's an anaphylactic reaction. Hypersensitivity is an allergic reaction, which is not as bad as an anaphylaxis, but it is still something that produces some of those same symptoms. Extravasation is some chemotherapy can be very, it's a vesicant, which means it's very damaging to tissues and surrounding areas. So if the IV is peripheral and that like infiltrates into the skin, it's going to cause a lot of sloughing of the skin and necrosis of that area. So that's extravasation. A lot of patients have a lot of anticipatory nausea and vomiting, and there are a lot of medications out on the market, particularly Zofran or ondansetron was specifically made for chemo-induced nausea and vomiting. So the medications are much, much better than they have been in the last few decades. And then some of the medications will cause cardiac arrhythmias. So here's a picture of extravasation. Pretty nasty, where an IV infiltrated and that chemotherapy medicine got into the tissues. This can lead to tissue necrosis. This can also lead to gangrene and amputation, possibly. These are some of the delayed effects. I'll just let you read those. Chronic toxicities, organ damage, most commonly to the heart, liver, and kidneys, post-chemotherapy, and these are long-term. Sometimes they're very late effects, will manifest many years later. Chemotherapy is given oral, IV, and regional. IV is the most common way for people to receive chemotherapy, and they do that through a CVAD or a subcutaneous port, a PICC line, because all these things decrease the risk of infiltration and extravasation, but it does increase the risk of infection for people who are having chronic low white counts and being immunosuppressed. It's kind of the lesser of two evils. Regional chemotherapy can be intra-arterial, which is just what it says. They put a catheter right into the artery and distill the chemotherapy systemically. Intraperitoneal, a catheter is placed into our peritoneum, and the chemo is directly instilled into the peritoneum, which acts like a big bowl and filters that. And also there's a dwell time for that. So let's have a dwell time of chemotherapy for 1 hour. After 1 hour, then they will drain that chemotherapy material out of the peritoneum. Intrathecal is into the subarachnoid space via a lumbar puncture. This is typically used to treat metastasis of the central nervous system. Intraventricular would be right into one of those 4 ventricles in the brain. In intravesical, chemo instilled into a bladder through a Foley catheter. They do use a lot of multi-drug treatments, so that means that you're going to get a little bit of this and a little bit of that. The advantage to that is the treatment is effective. Some of the disadvantages, it can cause toxicities when you are combining those medications. You may combine the increased risk of them to have a toxicity or a bad effect from that. And all these things are based individually on the patient, the staging, the grading, all of those things. So preparing chemotherapy, you have to actually have special training to do this. Regular general nurses do not administer oral chemotherapy meds on the floor. At Camden, the policy has always been that an oncology nurse will come and dispense that medication for you. And the reason for that is they are really under surveillance every year. They determine how much radiation they've been exposed to. They get blood tests every year to determine their white count and their risk for being exposed to all of these nasty drugs. These drugs can be absorbed through the skin, sometimes inhaled through the preparation. So they are done in like a negative flow room with a laminar hood. Of course, these would all be pharmacists that are doing this, and they have all of their, regular hazmat equipment on for that. So dose-limiting adverse effects really come with the suppression of bone marrow in the GI tract. So that means that if the bone marrow is significantly suppressed, then there may come to a point where the chemotherapy is stopped or the radiation is stopped, and there's a pause there until the patient can build up their cells again and go ahead and restart their therapy. It's also called myelosuppression. So myelo does not mean muscle, but it actually is the prefix for bone marrow. We've talked about GI disturbances. Some of these medications, chemos have what's called emetic potential. So the oncologists know that this is really going to make the patient sick, and they will prescribe the antiemetics sufficiently for that. So we're going to talk about what happens to each of these systems as a result of chemotherapy. So cardiovascular, we talked about EKG changes. It can also lead to heart failure. Nursing assessment, we want to be sure the patient's on a cardiac monitor. looking for arrhythmias, treating those with any antiarrhythmic meds, and then a focused cardiac assessment, which is going to be listening to heart sounds as well as lung sounds, every 4 hours. Also looking for peripheral edema, jugular venous distension, skin color, temperature, and listening for a pericardial rub. Respiratory, we're going to see some pneumonitis, which is what the COVID patients were developing. And then they also went into pulmonary fibrosis after that. But pneumonitis can develop 2 to 3 months after they're done with their treatment. They can also develop pulmonary fibrosis after their treatment with up to 1 year. So focused respiratory assessment, encourage respiratory exercises, encourage them to use their incentive spirometry, get up and walk around, take nice deep breaths if they need to, and also we might get cough syrups ordered around the clock so they're not coughing. Respiratory focus on the lung sounds. What is their work of breathing? Do they have a cough? What's the COCA of the cough? Listening for a pleural rub, because that will decrease the amount of air that they can inhale in and exhale out. What is their oxygenation and how are they managing their secretions? GI, all the usual suspects. Anorexia, so that means that they don't want to eat. They can have constipation because they get dehydrated and they're not really eating anything, but they do get constipated. Nausea, vomiting, diarrhea. They can get hepatotoxicity, which is toxicity to the liver, and then all these itises in their GI tract. So nursing and assessment intervention is going to be antiemetics, and those will basically be around the clock, antidiarrheals as needed, and a focused assessment. So nutritionally, we're going to be looking what is their daily weight. We're going to take a look at some of their labs. Albumin and total protein levels are directly related to nutrition. ALT, AST, ALKP, and total bilirubin is going to be liver function testing, taking a look at those. So with liver function, we may also see the patient have jaundice in their skin, in their nail beds, in their sclera. Listening for bowel sounds, assessing for distension, and determining their last bowel movement and the COCA of their stool. Nutritional concerns are a real problem for patients who have chemo. Again, we need to make sure that it's the best setup that they have in their room, that there are no things that are malodorous, they're not looking at their urinal, there's not a bedside commode sitting right there, all the things that would kind of turn you off and make you nauseous and not want to eat. Antiemetics around the clock, good oral care, especially if they have stomatitis or ulcers in their mouths. We can recommend viscous lidocaine, which is just a numbing gel that they will swish and swallow. And it just numbs it enough that they won't have any pain and they can maybe take a few bites of something. Hydration, making sure that they stay hydrated. This may come from IV fluids for the most part. Some of the chemotherapy meds will leave a metal taste in their mouth, so we want to be sure to offer them plastic silverware. And then these replacement drinks, shakes, ice creams, puddings, milkshakes, all of those things, and small frequent meals, just kind of like the COPD. Let's give them a little bit to eat, maybe 6 to 8 times a day, so they can get a little bit of nutrition over time. Energy conservation, appetite stimulants, that's going to come in the form of sometimes Marinol or THC or cannabis products will increase their appetite. Megace is another appetite stimulant, which is an anti-neoplastic. Foods that are high in protein, chickens, turkey, cheese, Greek yogurt has a lot of protein in it. Protein is what they need for healing and also for good nutrition. How to avoid or treatment for diarrhea. They should not be eating spicy or gas-producing foods. So broccolis, cauliflowers, Taco Bell, beans, any of those things are going to make that worse. They need low fiber, low residue foods. Make sure they have good hydration, perhaps avoiding milk products because that will make diarrhea worse. Here's another one about nausea and vomiting. I pretty much have said all of those. Stomatitis, avoid those lemon, glycerin swabs, undiluted peroxide, anything that contains alcohol because that is going to burn. We need to make sure that they have a soft toothbrush and that they have some chapstick or bliss sticks or something nearby to keep their lips moist. And again, the nystatin is mycostatin, and that is that swish and swallow antifungal to treat the yeast if they should happen to have that. And then the viscous lidocaine is that numbing gel that they can swish and swallow. GU problems, they can get nephrotoxicity. They can also develop hemorrhagic cystitis. So cystitis is an inflammation of the bladder, and then so you've got a bleeding inflammatory response in the bladder with hemorrhagic cystitis. We need to encourage hydration, so this may again come in the form of IV fluids. It may be ice chips, it may be popsicles, whatever we can get to count for hydration for them. Really strict INO, looking at the coca of the urine and how much urine that they're putting out every hour, looking at BUN and creatinine, and then focusing on the GI system. GU system, sorry. Okay, all of these things, focused assessment, you can read that. Duplicate slide. So, hematologic problems. Patients develop anemia, leukopenia, and thrombocytopenia. So nursing assessment, we're going to be checking out their skin. With thrombocytopenia, they may have some purpura, which is little ruptured capillaries, a lot of bruising. They may also have thin skin that is going to be really fragile and rip easily. With anemia, we need to be familiar with what is their SpO2 level. Do they need oxygen? Because they don't have red blood cells to carry enough oxygen around. Of course, vital signs, looking for signs and symptoms of bleeding as well as infection. So how we can manage anemia, blood transfusions, iron preparations. Erythropoietin is a normal natural hormone that is secreted by our kidneys, but with the kidneys not working well or the bone marrow not working well, we can give synthetic erythropoietin, which is Epigen, which is a subcutaneous injection that increases the production of RBCs and stimulates the bone marrow. Thrombocytopenia, we want to avoid injections because we're going to have an increased bleeding for that, as well as they may need a platelet transfusion. You can read this. We want to be sure that we're protecting the patient from sick people. In this situation, if you have somebody who's a cancer patient and they do have neutropenia and leukopenia, we need to notify the healthcare provider for a temp greater than 100.5. So that's a low-grade fever, but for somebody who is so immunosuppressed, it's something that would be a red flag for nursing. There are some medications that they use to increase the white blood cells, and those are filgrastim and pegfilgrastim. So that is Neupogen and Neulasta. So, and those medications are on your pharmacology chart that you have in Blackboard. Have to be careful on no real plants with soil because sometimes those come with bugs and bacteria and organisms that will put the patient at risk. If they bring fruits and vegetables, of course, they need to be washed well. If they have a pesticide or something on them, we need to be sure that everybody is washing their hands so the patient is not at risk. Alopecia, basically coping mechanisms. They should not be excessively shampooing, brushing, curling their hair, damaging their hair. Most all people lose their hair when they're doing chemotherapy. So, and there are a lot of things for that. There are lots of wigs out there. I know the Strucker Cancer Center will give like 1 to 2 wigs away to their patients who have had issues with that. You know, there's bandanas, there's hats, there's beanies, there's a lot of things that they can do to cover their hair and not have to, you know, deal with that and look at themselves. So there's something called chemo brain, and that is cognitive changes related to chemo. Most of the time it's long-term, it's short-term memory loss for the most part. Also, they can get some peripheral neuropathy from the chemo damaging the ends of the nerves. So just like a diabetic has that neuropathy, it's the same thing. Also, if they have a brain tumor, they can get increased intracranial pressure. Some of these patients who do have issues with the brain may need anti-seizure medications, short-term, long-term. Reproduction, chemotherapy and radiation will damage the reproductive organs, so we need to be sure that the healthcare provider is talking to the patient about, you know, particularly their age, you know, what is their hopes for reproduction later, so they can bank their sperm and or bank their eggs for when they are done with treatment. Now, while they are getting chemotherapy, they really need to be encouraged to use contraception, because most of these chemotherapy drugs cause teratogenesis, which causes birth defects to the baby when they're exposed to chemotherapy. So, and also 8 weeks after they complete their treatment, they should not try to get pregnant. So chemotherapy precautions vary by institution. You should always wear 2 pairs of gloves if you're going to be administering chemotherapy. Again, you're not going to be, as a brand new generalist nurse, you will not be administering chemotherapy until you have had proper training and have gone through the surveillance. But if you're dealing with a patient who has chemo, wear 2 pairs of gloves, double flush the commode if you're using it to get rid of something. Also teach the patient to do this. And also we need a special hamper or special bags. Yellow bags are like universal sign for chemotherapy stuff. So if you see a trash can with a yellow bag in it, then that patient has been on chemotherapy and have chemotherapy precautions for the next 48 hours. Again, we talked about this, monitoring for extravasation if they have a peripheral IME. Not going to go over these meds. You can read them, and you do have everything that you need on the chart that I gave you. Go through these questions. All right, we're going to go over radiation therapy now. It's one of the oldest non-surgical methods to treat cancer, and about 50% of all people do receive some kind of radiation when they're getting cancer treatment. So radiation, the doses are also very, they have their own recipe, individually figured out how much they need, what they need, what area it's going to be, and all of those things are really personalized for the person who's getting radiation. So there are, okay, let's get that. There is external radiation, which is teletherapy, which is what most people are going to get. It's the most common. Patient goes to the cancer center and they get their radiation treatment. Typically it's 5 days a week. It takes very little time for however many treatments that they need to have, 20, 30, 40. The oncologist will determine how long and how much radiation the patient needs. Internal radiation is brachytherapy, and this is when they will, perhaps to treat prostate or bladder cancer, they will put radioactive seeds into that area or close to the tumor to work on making it smaller, which is good because it minimally exposes the healthy tissue, so they have fewer side effects than they would have if they had chemotherapy or something. Internal radiation, when they do have this, the brachytherapy, they are emitting radioactivity. So these patients will be in a private room, they will be shielded. You have to spend a minimal amount of time in there, minimally exposed to that patient and the radioactive source, and you will wear a badge. It can come in a ring form, in a lanyard form, to determine how much exposure you had that day, because we can only have X amount of exposure to radiation in our lifetime. So these are some common side effects that come from chemo and radiation. We've pretty much talked a lot about all of these things. We'll go a little bit deeper into it. Some of the pulmonary effects, I told you patients can develop some pleural effusions if they've had radiation in the past. If they've had radiation to their lung or to their chest, pleural effusions are quite common. They have to come into the hospital and have that drained. It's called a thoracentesis, and they can take 1 to 2 liters of this fluid off of the patient, opens up their chest, and allows them to take big, deeper breaths than with that fluid gone. Cardiovascular effects, radiation-induced heart disease, not common, but it can happen in higher doses. Talked about reproductive effects. Coping, community resources, find out what their support system is. Do they need transportation? Do they need help? Do they have food insecurity? Do they need emotional support? You know, all of those things we need to look at as a nurse, but also get case management involved, maybe a social worker involved, so they can have, they know what the community resources is out there and are available, and get these people as much help as they need. Educating the patients on what to expect will help to decrease anxiety. Sometimes they don't want to know, but not knowing is sometimes worse, and not then knowing, okay, this medication is really going to make me throw up, and I'm going to throw up, 12 hours after I have my treatment. So sometimes talking about things will reduce the anxiety of it when they know what to expect, and explain that, this is a temporary situation. It's just going to happen, for the length of the treatment. Some of the treatment for leukemias will cause, actually, leukemia is a problem that can happen as a result of radiation. So the treatment for the cancer can actually cause another cancer to occur later in life. So leukemias are like that. Multiple myeloma, non-Hodgkin's lymphoma, and cancers of the bladder, kidney, ureters, and osteosarcomas, which are cancers of the bone. If the patient continues to smoke, this can significantly increase the risk of developing a secondary malignancy, and usually these malignancies are really resistant to therapy. So complications, malnutrition, we've talked about that. They get some fat and muscle depletion. Their body is not getting the fuel and the calories it needs, so it starts to break down the muscles. They get atrophy, they're weak. They should have some nutritional counseling as soon as possible, but particularly if they have lost 5% of their weight since the treatment started. So we need to encourage increase the protein intake. Soft, non-irritating, high protein and high calorie foods should be eaten throughout the day. So again, 6 to 8 small meals a day. in order to at least maintain their weight. And then nutritionally, on the medical side, we'll monitor their albumin and their total protein levels, encourage the use of supplements like Ensure, Boost, add some ice cream to that. Some patients like make it more palatable, or to put ice on it. Sometimes they will drink it that way. It seems to taste a little better if it's cold. They do get some altered taste sensation related to the chemotherapy, so we need to let them know that, again, that is something to expect, and no food will not taste the same, but that's, for the length of the treatment, that's the way it's going to be, unfortunately. Primary cause of death usually is infection for cancer patients, and these are the usual sites of infection. The risk of infection occurs due to ulceration, so anytime they break their skin down or have a sore in their mouth, this is a wide open area for bacteria to get into the system, travel to the organs, and cause a sepsis. Other complications are compression of vital organs by the tumor, and then neutropenia, which is a decreased neutrophil count, which is part of your white blood cells, can be caused by disease or treatment. There are some oncologic emergencies that can be life-threatening. We're going to talk about 3: obstructive, metabolic, and infiltrative. So superior vena cava syndrome is when there is an obstruction of your superior vena cava, which is up underneath your left clavicle, and that goes right into the right atrium of the heart. So patients will present with facial and periorbital or edema around the eye. They get distension of the veins in the neck, head, and chest. They may develop seizures, and they may report a headache. This is kind of a picture. You can see that this is everything coming from the periphery. This is the subclavian vein that is going into the right atria, and you have all of this engorgement and congestion. They get edema of the face, neck, and their upper chest, and they get that JVD as well. Another thing is spinal cord compression. I talked about that with the need sometimes for a laminectomy. If the tumor's in that epidural space, these are the symptoms that can cause persistent back pain. They can have some motor weakness. They may not be able to move their legs, or they can lose some of their sensation. It can be like numb, prickly, like somebody stabbing them with a needle. And also, if it's low in the cord, in the lumbar area, they can have changes in their bowel and bladder function. The other one is third space syndrome. So sometimes we see this has nothing to do with cancer. Patients who are really malnourished or have some other hormone or fluid and electrolyte issues can start shifting fluid from the vascular space, which is the vessel, into the interstitium, which is your subcutaneous tissue. So what's happening is all that volume is moving out of the vessel into the skin, and they get very edematous. They start to leak some of this fluid. These cells actually lose the integrity of their membrane, and so albumins and proteins and potassium, all of those things are leaking out and leaching into the subcutaneous space, which causes hypovolemia and hypotension, tachycardia, and decreased urine output. And the treatment is just a replacement, particularly of the plasma proteins. So this might be your patient's going to get an albumin infusion, and then maintenance fluids or those isotonic fluids to replace them. SIADH is a metabolic emergency. This is syndrome of inappropriate antidiuretic hormone secretion. So this is going to cause the patient to be hypercalcemic, can also cause tumor lysis syndrome. They can go into septic shock, and they can develop DIC. So SIADH is abnormal or sustained production of antidiuretic hormone. Cancer cells manufacture, store, and release ADH, and some of the chemotherapy agents that they're receiving will actually stimulate this release. So this is a syndrome resulting from an abnormal or sustained production of ADH by the tumor cells, and it causes water retention and hyponatremia. Occurs most frequently in cancers of the lung, especially small cell lung cancer, but it can occur in other types of cancers as well. Some of the symptoms, Some of the symptoms are weight gain without edema, nausea, vomiting, seizures, decrease in their reflexes, or they can become comatose. The treatment for SIADH is to correct the sodium-water balance. So they will do that with fluid restriction. We can give oral salt tablets and isotonic 0.9% saline infusions. And in severe cases, we may have to give them 3% saline, which is really hypertonic solution to replace those salts. They also use Lasix, sometimes furosemide, to treat the initial phases of SIADH. Really deathly because it can really drop the sodium level, which can cause them to have seizures, go into a coma, and die. So this is a serious, serious issue. So the next one is hypercalcemia. Those little cancer cells can secrete parathyroid hormone-like substances. These are some of the symptoms that we might see with that. Also, with degradation of the bone, that can pull the calcium out of the bone and into the blood and cause a hypercalcemia. This doesn't happen in a lot of patients, just 10 to 20% who have advanced cancer. Being immobile and dehydrated will contribute to hypercalcemia development. Serum calcium levels of 12 milligrams per deciliter will produce symptoms, and more than that, it can become life-threatening. Patients can also develop kidney stones, which can cause an acute renal failure. Treatment for acute hypercalcemia is hydration, 3 liters a day, and bisphosphonate therapy, which are those not menopausal drugs, those drugs to help prevent bone loss in women, like Evista, those types of drugs. Tumor lysis syndrome is again triggered by chemotherapy's rapid destruction of these tumor cells, and that the release of those contents into the bloodstream. It causes the serum phosphate to go up, so the patient's going to have a hyperphosphatemia, which there's an inverse relationship between phosphate and calcium, so inversely it's going to cause a hypocalcemia in the patient. Also can cause some problems and put the patient in acute renal failure, and it also is commonly fatal in patients. The primary goal is to prevent renal failure and to manage their severe electrolyte imbalances. Here are the 4 hallmark signs of tumor lysis syndrome. Those electrolyte imbalances there. Some of the early symptoms can be weakness, muscle cramping, nausea, vomiting, and diarrhea. It's a very grave prognosis if your patient develops tumor lysis syndrome as a result of their chemotherapy. All right, we're going to talk about cancer pain. course, we should always believe the patient when they say they're in pain, and also we can do verbal and nonverbal assessments of pain. And of course, our number one goal is to try to control this pain, either with medications or non-pharmacologic things, if they'll work. There is a huge undertreatment of pain, or there has been in the past. As I said, hospice and palliative care is much more civilized than it has been in the last few decades. With pain, though, there is needless suffering, there's decreased quality of life, which also can put a bigger burden on the family caregivers. It's very stressful to see your family member be in pain and not be comfortable. That's the one thing that everybody feels the most vulnerable about. Fear of addiction is completely unwarranted when we're talking about treating cancer pain. We talked about non-pharmacologic things the other day: music, guided imagery, massage, relaxation, maybe aromatherapy. I mean, there are lots of things that we can try to do to distract them from their pain. I think you can read that for psychological support. Some of the common fears of cancer, losing their independence is probably one of the biggest things. Also, disfigurement, emaciation, which is losing a lot of weight and becoming, almost just bone thin. Being dependent on somebody else. Sometimes we don't want to do that. Maybe they're the breadwinner and there's a disruption in roles or relationships. Worries about money. Worries that the loved ones are going to abandon them. And of course, always the fear of death. So the best thing we can do as nurses, we've talked about, just be available, be a good listener, also be aware of some things that maybe we can help. We can get case managers on board, social workers on board. Maybe their pain relief is not where it should be, so we can talk to the palliative care team, notify the healthcare provider that they need another pain regimen or they need their meds increased. You can read that. Okay. Always maintaining hope.